We move on to the next presenter, Dr. Sunil Rajendran, HOD and Senior Consultant, Department of Vascular Surgery, Star Care Hospital, Kozhikode.
Respected chairpersons and my dear friends, at the outset, I must thank the organizers for this opportunity. It was actually a fabulous conference. I would also congratulate the two teams which actually fought today morning, that venous session, venous team and the arterial team actually, and the postgraduates, they have done really well. I really appreciate their knowledge. And actually, I feel this topic, they covered most of which I am going to discuss in this topic. So what's the background? We all know venous disease is very much prevalent. It's actually very disabling and crippling if you see a patient like this with a very bad venous ulcer. It's actually lifelong liability and patient is actually very much depressed. And actually it's evolving into a new specialty called phlebology, and it's actually a very complex disease. But due to some reasons, I am not sure. This is my PG days in 2001, and the lot of concepts in surgery has changed and has been well accepted by surgeons. But some concepts in venous disease have still not been accepted. A concept like, we all know for MNG, we don't do subtotal thyroidectomy, we do total thyroidectomy. But then some concepts of venous disease has not been accepted well by surgeons. You can see Pradhaban here. And because of that, many of these concepts have not gone down well in the clinical textbooks of surgery, even Das or Bailey. And so what happens is that other specialties like our colleagues, medical specialists, claim to be the final word in venous disease, and slowly we surgeons are losing ground. So based on this background, I thought I'll share 10 practice points which might help surgeons in a clinical practice. And this 10 practice points are not only based on my clinical experience, but also based on these two recent guidelines published by European and American societies. So first question, do we really need to treat all patients with varicose veins? The answer is actually no. If you really go by guidelines, you need not treat any patient with C2, C3 or even C4 disease. You need to treat patients only with C5 and C6 disease. So if you ask me, need not treat even this or even this patient if it doesn't have any symptoms. So the invasive treatment is not recommended for any patient with asymptomatic varicose veins. Next is clinical evaluation of patient with varicose veins. Obviously in examinations, we talk about all these tests, but in clinical practice, I am sure no surgeon does any of these tests in the clinical practice. Basically, we end up doing ultrasounds in our clinics, where within about 15 to 20 seconds, you can rule out venous disease, or you can assess severity of venous disease. So basically, all the clinical tests are being largely replaced by a OP-based ultrasound evaluation. But having said that, you should actually just see whether patient is having symptoms which you can correlate with his varicose veins. Patient may come with all this disease in your clinic. Don't jump and treat patients with varicose veins. And if you're still not sure, you give them a trial of compression stockings. If they improve, you can still treat these patients. So if you're not sure of the diagnosis, or not sure whether veins are correlating with patient symptoms, don't jump into interventions. Vein mapping, we talk about, but we often don't do. You hardly get normal anatomy like this in clinical practice. You can see all these weird anatomies and in clinical practice. So basically, you should actually decide which vein to treat. So you can see this is a patient with a normal SFJ and SSV, but it's small perforators arising at the knee. At another patient with a normal proximal GSV and a big mid-thigh perforator, and you can see a vein below the mid-thigh perforator is dilated. So basically, the anatomies are very much varied. You don't get a constant anatomy in patient with venous disease. And on top of that, you get weird report from radiology colleagues. In this patient has been reported as a reflux at SF and SP junction, but when you do with another scan, they say everything's normal. So keeping this in mind, like if you were to treat a patient with pancreatic cancer, I don't think you would actually operate upon a patient without seeing a CT scan. And likewise, when you get a patient with venous disease, do not offer intervention unless you have a surgeon documented ultrasound scan. Fourth point, which reflex is more important? We often talk about reflex at the saphenofemoral junction, but we don't talk about reflex at the at the great saphenous vein or the axial veins. But actually, if you ask me, if this reflex does not get transmitted to the axial vein, it is actually not significant. So the reflex which is more important is not the saphenofemoral junction reflex, but reflex more important is the axial reflex. As you can see, you can get even isolated GSV reflex in 20% of patients. So this is the video of a patient having significant GSV reflex. But also beware of a patient with a large great saphenous vein with no significant reflex. You can see in this patient, vein is so huge but no significant reflex. This is a patient with a proximal DVT. So the point is do not intervene in a patient without a definite reflex in axial vein. So actually the GSV reflex is more important than the reflex at the saphenofemoral junction. Which available modality is the best? It was often told and taught that surgery has got high recurrence rates. There is always a debate about should we strip GSV or not, but stripping of GSV should be the part of any surgical procedure. And as surgeons got used to doing ultrasound, the recurrence rate of open surgical procedure also came down to 5 to 10%. Actually, in our clinical practice, whenever I do surgeries, we use intraoperative ultrasound, which actually enhances the results of open surgery. I use ultrasound to mark the vein preoperatively, also to ensure that the vein is in the stripper is in the right vein. And we have published this data, and actually with this technique, our recurrence rate has drastically dropped after open surgery. Endovenous laser, initially it was thought that it is a very, very good procedure which can replace surgery, but there are studies which have shown that the recurrence after endovenous procedures are also pretty high. The glue is often talked about recently, but actually the glue also has its own share of recurrences. So basically, if you ask me, all the procedures are equally effective and recurrence rates of all procedures are less than 10%. So which is the best modality? If you really ask me, it's not glue, surgery, laser or RF. It's actually a well-done ultrasound by a surgeon is the best modality of treatment. If you don't have laser, do surgery, the results is equally good as laser treatment. So there is no evidence to say that any modality of treatment is better than other. It's all hype in the social media, but don't get carried away with that. Should we address bunch of varicosities? Yes, these bunches has to be addressed. There are many methods to treat it. If you go to external literature, they often talk about sclerotherapy to treat such bunches, but if you look at their data, they often talk about more of C2 and C3 disease. But Indian data is different, where you can see our own paper where we got more of C5 and C6 disease. So we get more complex disease. And so for us, sclerotherapy is not a good option for this huge bunch of varicosities, and often we do hook phlebectomies. And when this is done with ultrasound guidance, the results are actually pretty excellent. And you can see the video of how we do phlebectomy with ultrasound guidance. So don't leave behind any superficial varicosities. They can be a focus of future recurrence. And do we need to chase perforators? That is one of the important questions. If you see any ultrasound scan in your clinical practice, radiologists will report a lot of perforators, but actually if you ask me, you need not address any of these perforators in this scan. So if you go by latest evidence, there is no need to treat perforators in C2, C3 or C4 disease, and treat perforators only in patients with C5 and C6 disease. So don't go after all the perforators. And actually, there are a lot of techniques to treat perforators. We can't do any of these, but of late we have been trying to do what is called ultrasound-guided avulsion of perforators without putting a formal incision for the perforators. And actually, if you ask me, multiple perforator ligation are generally not needed in most patients with varicose veins. How to approach venous ulcers? Not all leg ulcers and skin pigmentation of the venous ulcer. Don't go after any pigmented leg with ulcer and think they are due to venous diseases. So always just try to confirm whether the ulcer has got any correlation with the duplex finding, and don't just go on treating the ulcer. And also beware of ulcer with chronic edges like this. They won't heal with any of your ablation techniques or surgical techniques. And also think about factors like ankle fixity and decrease calf muscle bulk, because they may be the causative factor for non-healing ulcer. So you can obviously do compression therapy, but one of the important technique which you should adopt in a practice is that when you have a chronic ulcer, just convert it into acute ulcer. So we do what is called ulcer excision and grafting. This is how the ulcer excision is done. All the fibrous tissues are excised and make it into acute ulcer, put the patient on VAC dressings, and then do skin grafting to give long-lasting result. They won't become better with your usual compression dressings. Reintervention for recurrences, how do you decide? Obviously, we all talk about all these things as a cause of recurrent varicose veins. Obviously, they are all the causes, but generally, don't treat only patient if he is having recurrent symptoms, and don't chase superficial veins that are coming up after the procedure. And redoing superficial procedures is not always the answer. Don't keep on doing procedures like sclerotherapy, laser, surgery, etc. And always, if you have to do a redo, always choose endovenous procedures if available, and redo surgery is actually not recommended. But still, if patient is having persistent symptoms, think of rare causes like pelvic congestion syndrome. These are not very uncommon. And also think about iliac vein obstructive disease like this, which is also not very uncommon. There are two types of iliac vein disease. One is non-thrombotic iliac vein lesion, where iliac vein can get compressed at any of these points shown here. So again, another female with ulcer, multiple procedures done, and then as you do the angiogram, you can see the venogram is absolutely normal. You don't find any lesion there. Then at this point, you do what is called intravascular ultrasound. Ultrasound is actually, there is a probe which is actually kept in the vein, and as you pull back, you tend to see the vein diameter. And as you see, at some points when you pull back this IVUS, the vein is getting compressed, really compressed over here. And these are the culprit points which needs to be addressed. So what we do is we measure the iliac vein diameter, and if diameters are really narrow, like you can see in this common iliac vein is only 71, actually it should be around 200 millimeters square, and then you actually place stents in these patients to relieve that obstruction. So this is the post-stent, and then you relieve the obstruction. Again, you could have cases where post-thrombotic patients after DVT, they can also have iliac vein obstruction, not very uncommon. Again, a patient of this, and you can see after IVUS, the severe narrowing of the iliac vein, and then again, you put stents and open up the iliac veins, and basically, these are some problems which you can face in reality. Is deep vein pathology a reality? Yes, actually, patients won't give history of DVT. About 30 to 40% of patients don't give history of DVT, but they really would have had DVT sometime in the past, would have gone unnoticed. And there is actually latest recommendation which say that all patients with class 3, C3, C4, and C6 disease, you should actually evaluate deep vein before you actually go in for superficial venous intervention, either at least by a duplex ultrasound. So key point is, redo superficial vein ablations are better done after evaluation of deep vein pathology. Don't keep on treating superficial vein pathology if you don't have find a cause. So take home message, approach to patients should be individualized. A new investigation is nothing but a surgeon performed duplex. Which ablative modality is the best? It's an ultrasound, and all modalities are equally effective. And when you think any unusual presentation, think of deep vein pathology. Again, one of the old photos I got recently, my Rajan sir in the OT, he is one person who actually thinks about progress, and he always encourages change in surgical practice. So I think as surgeons, we should also think change. And if you don't change, you will be overtaken by other specialties. And like Sri Kumar said, like DVT and venous disease are actually domain of surgeon. It's a surgical disease, and it should not be let away for other specialties like be it radiologists, cardiologists, or physicians. It's surgeon's domain, and you should actually recapture the domain. With these few words, I thank you for patient hearing.
Thank you, Dr. Sunil. It is an excellent presentation. You have all the 10 points you have mentioned are well taken. And since we are running short of time, I will just entertain Professor Ajay Kumar.
Sunil, very enlightening talk. Really appreciate you. Question regarding stenting the venous system. you said compressive areas are there with narrow lumen. If you put a stent, there is a very high chance of stent occlusion, isn't it? What is the occlusion rate?
In non-thrombotic iliac vein lesion occlusion rates are very minimal, less than 1%. In thrombotic rates are 20%, but in non-thrombotic is less than 1%.
Okay. And what could be the reason for this compression? You showed some areas of compression. This is extrinsic or what is the cause?
It is extrinsic because the artery compressing on the vein at certain points, and over time it forms a fibrotic bands around the vein. It's very common.
Okay.
Babu sir.
One is a comment. The new edition of Bailey says there is no role for any of the clinical tests, which is the time-old test. Nowadays, there is no role for all the Trendelenburg, all those tests. Dogmatic state, there is no role. So I don't know what the students are going to do. Second is the short saphenous vein. They are describing it as small saphenous vein. Is it a change like that? Short saphenous to small saphenous vein.
No, I have no idea, sir.
Because this book is giving all headings. Instead of short saphenous, they are telling small saphenous vein.
It's right, sir. It's great saphenous vein and small saphenous vein now. It's accepted as small.
Yeah. Long and, great and small. This is
Yeah,
the
great
new-
and small.
Great and small.
The last
Yeah.
by Professor Raj.
Thank you, sir. Just no question, Sunil. It's a wonderful lecture. I congratulate you. One point to be stressed. He told that there is no difference in the recurrence rate, whether it's a laser or a glue or something like that. The message should be very clear. A lot of people are doing a lot of hype in social media regarding glue therapy. There is no advantage in recurrence, and two major complications are very important. We should understand it. One thing is glue is never absorbed. It will remain as a concrete slab in your vein for lifelong. Second is allergies are reported from different parts of India. More than 20 cases are reported from different parts. In that case, you have to excise the whole vein with a long incision and treat it. So we should be aware that glue is not a major difference, or glue is not the ideal treatment when considering varicose vein management. Thank you.
Last comment, sir. Thank you.
My take on Babu Sar's statement, Bailey says no need for clinical examination. Maybe that is correct in UK, where the vascular sonologists are very specialist people who are seasoned to do and find out reflexes and map veins. In our situation, it is better to do clinical examination, because some of the sonologists are not at all focused, and they may give you a poor report. Patients come to you with a very poor report, and if you believe that, you are going to do wrong to the patient. You have to clinically examine. Sometimes short saphenous veins are not looked for, accessory saphenous veins are not reported. Things like that are there in our country. Until focused sonologists or Doppler people come to venous imaging, we may have to continue doing clinical examination.
Just to conclude, because whenever I give talks like this, people say, surgeons say we don't have access to ultrasound. We cannot treat varicose veins without learning ultrasound. You should learn ultrasound if you want to treat varicose veins. So grab an ultrasound and be a good sonologist, then you be a good surgeon. And this is our domain. Please don't leave this to radiologists or physicians. That's the basic message of the whole talk.
Sorry to interrupt, sir.
As Dr. Professor Binny said, the clinical test is actually important, though it is fading from the textbook. Newer textbooks are not talking much about the clinical test. Still, I teach these clinical tests to students because that will give them a comprehensive idea regarding the venous drainage and also the various systems draining the lymph node. Just put an emphasis on the anatomy and the drainage pattern. I still teach the clinical science. So thank you. We are running out a lot of time, and we are running short of time. And thank Dr. Rajendran for an excellent presentation.
May I request Dr.